Well,
Recording in progress.
the Lord has spoken. Okay. Welcome to Grand Rounds. I'm happy to introduce. My name is Dan Saltzman. I'm the division head for pediatric surgery, and I'm going to introduce our newest partner, Dr. Alexa Robbins. Dr. Robbins, undergrad, Boston University, med school, Georgetown University. Did a rotation away here. On acute care, is that what you did? Surgical critical care? And then surgical residency here at the University of Minnesota. She's got a master's in healthcare administration, a palliative care fellowship, classic underachiever, and did a pediatric surgery fellowship at Colorado Children's Hospital. And then we worked very hard and successfully recruited her back here. I will say that when I was looking at your CV the other day, and I saw that when you finished your residency, you had nearly over 20 publications, 2 book chapters, lots of oral presentations. You make us very proud. And so I'm just delighted to see Alexa here and have her as my partner and to listen to her give us grand rounds on pediatric surgery with palliative care. And I will say that she's one of the only palliative care pediatric surgeons in the country. The only one. The only pediatric surgeon in the palliative care position. Okay. Thank you.
All right. So we're going to go through a couple of things today. We'll talk about some recent innovations in surgical communication, which applies to the adult world as well. Then we'll talk about some things that are specific about pediatric surgical palliative care. And then finally, we'll get into some of the emerging research about goal concordant pediatric surgery. So many of you have heard my spiel before about palliative care and why all surgeons are also palliative care providers. But just to reorient, what is palliative care? So when people initially describe it, when I started, when I was back in medical school, would be, when we're ready to pull the plug or give up or be done. Sometimes it's not hospice, but I don't know how to describe what it is. So how many palliative care providers introduce themselves is a team that helps care for patients with serious illnesses in managing complex symptoms and helping to prepare for the future, or a team that provides an additional layer of support to patients with life-ending or life-altering conditions. So there's this difference between primary and specialty palliative care. Primary palliative care are principles that all providers, all surgeons, all doctors should be able to do. Elicit goals of care, assess symptoms, have good communication, ensure good transitions of care when you're moving towards something like hospice. Specialty palliative care is not just the doctors. It comes with a huge team. They've got chaplains, they've got nurses, they've got social workers. In our sphere, they've got child life specialists, they've got family practitioners who help support siblings and parents who are going through a difficult time. They provide a lot of detailed information about hospice eligibility and what that looks like. And then they have advanced symptom management, so their toolkit for nausea and pain is extensive. So this is not a new thing. This American College of Surgeons has a statement of the principles of palliative care that came out back in 2005. So that includes things like all surgeons should respect the dignity and autonomy of patients, surrogates and caregivers, arranging continuity of care, recognizing the physician's responsibility to discourage treatments that are unlikely to achieve the patient's goals, striving to alleviate pain, some of the things that are just inherent to our job. And then number 3 here, which talks about communicating effectively and empathetically with patients. And since I did fellowship, this area has exploded. There's now hundreds of us, of surgeons of all disciplines who've also done palliative care fellowships, including Cassandra Palmer at Regents, and Emma Schaefer is currently doing that in her residency. And there's a committee within the American College of Surgeons for surgical palliative care. There's a textbook about it. There's exploding research in this field. There's a chapter in the American Academy of Hospice and Palliative Medicine for surgeons. So if anyone is interested coming up, I think this is an important niche to your practice that you should consider, and I'd love to talk to you about more if you're interested. So many of us know of Gretchen Swarzy and her work about best case, worst case. So this is one of the many communication tools that can be used to help families, particularly patients and families who are going through a difficult acute decision, which is often when they're interacting with us. I think that this is one of the main things that surgeons can provide as in our role doing primary palliative care is that we don't have, for most patients, we don't have a long-term, their entire life relationship with patients, but we meet them at a crossroad where they're trying to reassess how intense of interventions they want to continue going forward. So best case, worst case, which I understand you guys had your OSCE or your recently had sort of you're learning about this tool particularly, but the resident team. But essentially what you do is you have a piece of paper and at the top you put the past medical history, perhaps some things about functional status, how the patient's baseline life is, and then you describe the choice in front of them, proceeding with surgery or doing more of a comfort focus. Noticeably there, the conversation is not we're going to operate or do nothing. It's we're going to operate or we're going to medically manage your symptoms, etc. Making sure that there is a robust other option other than steel. Okay. And instead of getting into sort of complicated statistics, which are very difficult to interpret as a patient, unless it's a 10% versus a 90% difference, how you make a decision with a 23% risk is really challenging, especially when you're emotionally charged, which all of these conversations are inherently emotional. So best case, worst case provides an opportunity to tell stories, and that can help with the visualization for a family about what they might be signing up for or what they can hope for. So a best case for total colectomy could be described as undergoing a successful operation, then requiring multiple days in the ICU, multiple days in the hospital, unlikely to go home after this. Most likely the impact is significant enough that grandma's going to be in the nursing home. Worst case is not, in fact, that they die in the OR. It's that they undergo a big surgery. They have difficult symptoms to manage in the ICU. They are in the hospital for a long time and they pass anyways. And then your job is to put your best guess at where the most likely is on that spectrum. Comfort care, the best case scenario is that we get your symptoms under control, we treat you medically, and perhaps you can survive for days to short weeks if you recover from your acute sepsis. And we can get your family here and have some important memory making and keep you comfortable. And the worst case is that things escalate rapidly and we keep you comfortable, but we can't keep you alive until your family's here. And then once you describe these various scenarios of what life could look like, depending on the spectrum of outcomes for each option, you say to the patient, what's most important to you now? And what's helpful about this tool as well is that the family has this piece of paper later. So when Aunt Petunia shows up from California and is like, you let grandma die, you can describe the thought process of what was happening, and you have a piece of paper to reference for your emotionally activated brain. I think a couple of things that were helpful to me from palliative fellowship that I bring up is thinking about how do you ask about functional status, or how do you help remind a patient who has had a lot of decline recently to help give context to the family about what their day-to-day life is like and what their quality of life is like. And so I used to ask questions like, what does your average day look like? Thinking through like how much are they out of bed? How many of their activities of daily living are they able to do for themselves? Because sometimes the son in the room who's trying to help out doesn't realize that mom spends 80% of her day in her bed. And then what brings you joy? For grandma that hangs out in bed 80% of the day, that her life might be great, but it might also not be. And so getting some perspective on that can help flesh out that past medical history, functional status part to give context of what the baseline is. And then post what's important to you. I feel strongly that you should listen to what they tell you is important to them, and then you should make a recommendation about what to do. They are allowed to push back and to tell you, that doesn't feel right to me. Let's deliberate about whether we should proceed. But I think giving the decision-making burden entirely on the patient and family does them a disservice. So Gretchen Swarzy's lab has expanded to include a best case, worst case for the ICU, which includes sort of a temporal change in where your best case lies. And she also has a best case, worst case for nephrology. There's some nice short YouTube videos describing these tools on the Patient Preferences Project, if you're interested. And then she ramped this up to go from just acute emergencies to considering how we consent patients in general. She had a JAMA Viewpoint series in 2023. This is excellent. Each of these articles are only about 2 pages, and they're really well written, really thought-provoking. I would definitely recommend printing them out for the next time you're waiting for the OR to turn over. So the 5 pieces are: provide your opinion, don't hide it, focus on the goals of surgery, promote deliberation, not technical education, present the downsides of surgery, not just the risks, and when surgery is a bad idea, focus on goals. So let's start with provide your opinion, don't hide it. So I think as surgeons, we really want to promote autonomy and a patient's right to self-determination. And so when it's obvious, like presumed consent or would not offer surgery. I mean, we're not going to offer hospice to a young, thriving patient with colon cancer, or in a patient who has no hope of recovery. We don't offer operations. But in the middle, or when we feel one way or the other about how reasonable an operation is, we've all seen surgeons who describe both options as if there's true equipoise between them, because we want to allow them to make the decision. However, it doesn't truly promote autonomy to offer an untenable option. So you give patients a situation of a non-choice choice. And then when they pick surgery, we think they're unreasonable, right? So one of the things she talks about is you should give the patients context of both what on average people would do in this situation to operate or not, and you should offer your opinion. So if you're in the not in presumed consent, but you're in the surgery does more good than harm, you would say something like, usually we do surgery for this, or I'm hopeful that surgery is going to be able to help you. If you're in the surgery does more harm than good, saying, usually I wouldn't operate in this situation, or I'm worried surgery is not a good idea. And in the middle, you can just be transparent and say, there's not a right thing to do here. I really think we need to deliberate together about the right choice, because to operate or not, honestly, both options hold a lot of merit. So don't make the patients create the context. You create the context for the patients based on your clinical judgment and experience. Focus on the goals of surgery. So surgery has this traditional fix-it model, which is there is a ABI of 0.3, and I am going to bypass that. But bypassing that to get more blood flow is not the goal for the patient. The goal is to have a leg that doesn't hurt and will not clot and will not cause death, right? So surgery can only really do 4 things for patients. It can help them live longer, feel better, prevent disability, or obtain a diagnosis. And so these are the goals you should be talking to your patients about. Dr. Schwarzy cites this paper that looked at when she talked to patients about their carotid surgery, carotid endarterectomy, and what they thought it was going to do for them. And for some patients, they said it was going to prevent stroke risk. For many, they thought it was going to get rid of their headaches or other symptoms. And so when they didn't realize that even though she was promoting blood flow, the goal was to prevent disability. And so when their symptoms did not improve, they went through a big operation with potential complications without being aligned on what the actual benefits of that operation were going to be. Next, promote deliberation and not technical education. So we are all guilty of this, right? I am guilty of this. I get in there and I draw the gallbladder and the biliary tree, right? And I spend a bunch of time educating my patients because I do want to empower them with information. However, the study looked at how many minutes or what percentage of the conversation was spent on each of these topics. And The two long ones are explanation of disease and explanation of treatment. There is no amount of time you can spend, even with a fellow physician patient, to bridge the asymmetry of information. However, when you look at the pros and cons, it was less than 1% of the time. When you look at empathy, it was less than 1% of the time. The risks are less, the uncertainty is less. And so what she means to say is you should spend more time talking about, deliberating about the pros and cons of an operation. And at the end of that conversation, for patients that are interested in getting the full map, looking at the CT scan, getting a lot of details about choledochal cysts, those are the patients you can spend a lot of time getting into the details. But for many patients, this information is confusing, it is difficult to retain, and you spend 20 of your 30 minutes drawing pictures and less time talking about the impacts of surgery. On that note, present the downsides of surgery, not just the risks. So as surgeons, we are, the medical legal context, we are conditioned to avoid complications. We have M&M all the time. We are quoted on our quality based on our complication rates. It's always top of mind for us. But for patients, that's only one piece of the pie. Every patient that has a surgery is going to experience expected bad stuff. They're going to have pain. They're going to have to be away from work. They're going to have to pay money. They're going to have functional status changes for a period of time. So those are expected things that you're taking on with a trade-off for an operation. And then there's possible bad stuff. There's the major changes and there's reportable complications, like the things we always talk about, dividing the common bile duct, causing leaking from your clip, causing extensive bleeding. But there's also like bumps in the road, the postoperative ileus, the urinary retention, the NG tube that doesn't work and they're vomiting, the shoulder pain after laparoscopic surgery. Then there's major changes. You take out someone's entire colon, they're going to have chronic diarrhea for the rest of their life. How do you talk about that? And then there's the things you can't even anticipate, the corneal abrasions, the numbness from operative positioning. And then finally, there's falling short of our goals. We could go through a huge operation where I do my absolute best and there is still a microscopic margin. So this all seems like, why would anyone in their right mind have surgery if you talk about all of these things, right? We don't want to scare our patients or, remove all hope about what they're going to go into. But she describes, having the conversation say, okay, there are inherently some challenges that come with having an operation that are hopefully worth, in the long run, your goal, which we have explicitly stated what the goal is. There are some things that can happen after surgery, bumps in the road, things that we can't anticipate, some changes because of the anatomy change in your body. And then there's the complications that we have to talk about from a medical legal perspective to try to prepare you. And finally, despite our best efforts, there's a chance that we fall short of this goal. So try like that level of summer, not like go into corneal abrasions for every patient that you consent, okay? And then finally, when surgery is a bad idea, focus on goals. So when surgery can't meet the goal, you cannot extend someone's life because of an operation that the medical team wants you to do. Instead of coming in and saying, ma'am, you're not a surgical candidate, or it's too risky, share disappointment. I really wish that my surgery could do that for you, but I cannot accomplish that goal. When reaching the goal is unlikely, so say you're a patient with, median articular ligament syndrome or, biliary dyskinesia, where you're like, is this actually going to help their pain or not? Given my concerns, how do you feel about going through surgery and all of these known challenges and potential bad outcomes when there's only a small chance of reaching your goal? And then finally, the situation where you can meet the goal, but you might leave the patient worse off. So once again, her Viewpoint series talks about provide in your opinion, don't hide it, focus on the goals of surgery, promote deliberation, not technical education, present the downsides of surgery, not just the risks, and when surgery is a bad idea, focus on goals. If you're interested further, she has just like her best case, worst case videos, she has a video that talks about better conversations for informed consent and how you would actually set up your 20-minute visit with someone to talk through all these things concisely. Show your cards, identify the goals, present the downsides, deliberate, make a plan. So I'd recommend watching this video. It's better conversations for better informed consent. And then one of my pitches is to bring the fundamentals for communication in surgery to our residency. So Dr. Schwarzy just started in a couple of residencies throughout the country this algorithm where in the first year you learn about avoiding cognitive traps, 2-minute rant. The second year you talk about some additional palliative skills. The third year you do the better conversations, like what we just talked about. Fourth year you do your best case, worst case. So it's like a lot of different communication tools that come through as fundamentals, just like you would be doing FLS or FES. So a lot of stuff about better communication, interesting ways to kind of reframe how you might be having these conversations. And I'd love to hear what people think about this when we get to questions at the end. I'm going to take a hard right and talk about pediatric palliative care. So there isn't a lot of overlap between pediatric surgeons and pediatric palliative care formally in people who've done fellowships. But once again, we do a lot of primary palliative care too. But it's different than adults. The epidemiology of patients who are cared for by palliative care is very different than in adults. Oncology only represents like 20% of those patients. And we also have, complex cardiac kids. But then we have patients with congenital or neurologic or genetic issues where palliative care is involved for their full 20 years of life. And those patients, their trajectories are incredibly uncertain, and it's hard to prognosticate and help families understand what to expect. And then you have the patient themselves, how they experience their illness and how they can interact with you and how they are coping is different in a toddler versus a 16-year-old or in a neurodivergent kid or in a patient who can't interact with you at all. And then there's family dynamics. There's no patient who their experience is not also impacting their siblings or their parents' lives. And then there's the additional challenges in the fetal prenatal period and neonatal period when parents are trying to figure out how to make decisions for their child when they don't even have any lived experience of being a parent to draw from. So what's the current literature about pediatric surgery and palliative care? There's a couple of papers, and we're going to talk about all of them. So one looked at pediatric surgeons and palliative care providers and thinking about the utilization of palliative care teams within pediatric surgery departments and pediatric surgery patients. So 40% of pediatric surgeons said that they consulted palliative care, and 67% of palliative care docs said they were never consulted by surgeons. Palliative care physicians were more likely to report that their involvement was too late, and surgeons report that the appropriate time for involvement was when the serious illness started to deteriorate, versus the palliative care physician said at the time of diagnosis of these serious illnesses is when we should get involved and start to develop relationships. And then more palliative docs thought that intensive interventions could be considered a form of palliative care than surgeons. And more common reported barrier to palliative care consultation by surgeons was that the surgeons thought that the parents would think that surgeons were giving up if they consulted palliative care. And then sort of some of the big, the pediatric health information database, looking at some studies that looked at that, found that in pediatric patients during their last admission of their life, their terminal hospitalization, 50% underwent some kind of surgery. Now, surgery in a lot of these studies is defined as anything that had a general anesthesia or procedural sedation. So no local, but things like endoscopies or bronchoscopies or intrathecal chemo would count as a surgery in a lot of these studies, just to give context. It's not like we're doing XLAPs on everybody, okay? And 20% of those patients died within 48 hours of their surgery. So we care for many of these people at the end of their life. 84 of these 4%, these are lower ones are for smaller retrospective single hospital studies, but 84% had palliative care involved, but only 36% were pre-op. And of those who had palliative involved, they were more likely to die, those without palliative were more likely to die in the OR, have surgery within 24 hours of death, and undergo a full resuscitation attempt. Now, once again, this is correlational data, but interesting nonetheless. So there's this cool group called, well, cool in my mind, Pediatric Palliative Care Research Network. So there's 7 major children's hospitals that are collecting prospective palliative care data. They have almost 800 patients at this point. And this group looked at that network and tried to map the trajectories of the number of interventions that these children have and when. And of their population, they looked specific. These couple studies looked particularly at the kids at Boston Children's, so they could get some more data about them beyond what was just in this collaborative effort. And so, of these kids, their mean age was 8 years old. So, included sort of the prenatal patients we get consulted about, the neuromuscular disorder patients that are in their 20s, wide range of pathologies. The most common diagnosis for cardiovascular and oncology. But like I said, for the palliative care group, that's only 14% of the types of patients that they care for. And then the mean number of complex chronic conditions was 5. So these kids have a lot of challenges. And then, like we talked about earlier, 60% of them were still alive at the time of analysis. So they looked at patients from 2017 to 2021, and then this study was done in 2023. So many of these patients have been seeing palliative care for a while. It's not as like adults where to be on hospice, you have to demonstrate you only have 6 months to live. Or that's their best guess. And of this population, 96% underwent an intervention. So just because you get palliative care involved does not mean that we don't operate anymore. Almost all of them had some kind of intervention. The mean was 17 interventions, with half of them getting 13 plus. So they looked at, you're not meant to be able to read this text, but it's meant to describe different patterns of interventions. So they looked at it based on type of disease process. So the red is malignancy. In those patients, they had a ton of interventions right after they got diagnosed. And that dotted line in the middle shows when palliative care got involved, pretty soon after their diagnosis. However, when you look at neurologic, which is orange, they, over the course of their life, had interventions. Many of them, it's one of the bigger groups of interventions, but they were spread out over the course of their trajectory. And palliative care usually gets involved within a couple years, not right away. And then, so the high acute life-limiting illnesses undergo high volume, high risk intervention, immediate post-diagnosis period. So that's like prematurity in the pink, hematologic, or in purple, malignancy in red. And then the neurologic or yellow genetic has a little bit more, but a wide tail. And then patients with more complex care chronic conditions, they had more procedures, unsurprisingly. So every additional complex care chronic condition you had 3 more procedures done. And of note, to plug for pediatric surgeons, general surgeons, enteral access was one of the most common surgeries. We touched a lot of these patients, 65% of the cardiovascular patients, 73% of the genetic metabolic patients, prematurity, respiratory. And in this study, 21 different teams did interventions, and the general surgeons did the most of them. We did 20% of them. But when you think about the role of palliative care to also help us coordinate vastly multidisciplinary care in these patients. Think about the 21 teams that are operating on these kids, and having palliative care help families navigate sometimes conflicting things going on is exceedingly helpful. So what's our responsibility then as general surgeons and peds who very much take care of these children? High quality care in serious illness is predicated on goal concordance, especially because in many operations, there's trade-offs when you're trying to decide whether to operate or not. So I always bring this up because when I was a palliative fellow, I had a couple of residents that would walk in the room and talk to families and just go, "What are your goals of care?" And I was like, that's a really hard question to answer with zero context, right? So in fellowship, when I was working with adults, these are the 4 questions I would ask patients. This is just my shorthand. This is not like a proven thing, but what are you worried about? What are you hoping for? What are you expecting to happen? And is there any health status or outcome that would be unacceptable to you? Now, in peds, the pediatric palliative care docs have these 6 cardinal questions, which of course are a bit more lengthy than mine because we're usually concise as surgeons. But some of those questions, like what I talked about earlier with best case, worst case, thinking about like what is your average day, it really helps families when you try to talk about their child outside of their medical illness. So starting with the question like, what is your child like as a person? Or can you like opening a conversation by saying like, can you tell me a little bit about what your child is like when they're not in the hospital? Then saying, what is your understanding of your child's illness? Try to get the context of what they, we don't need some of these parents will bring out like 5 documents to give you their full timeline. You don't need that, but just like the general overview. And then they describe it as, in light of this, what's most important for you? What are you hoping for in the short or long term? I would just use the, what are you hoping for? And then what are you worried about? And then the last 2, I think, are also looking at the family and the parents, which is additional things in peds. Not that it's not important to value families and parents, families and loved ones and parents and children and adults, but it's different in children. So where do you find your strength and how well is that working for you? And how are you getting by day to day in terms of resources? A couple pediatric palliative care documents describe these goals of care contexts of being, by finding out about goals, you can figure out as simple as, is their priority live as well as possible or live as long as possible or both? In the adult world, we talk about this quality versus quantity, right? And so what families might say to you, if it's live as long as possible, is we can't even think about not trying the next treatment. We need to know we did everything we could to keep her with us. We continue to pray for a miracle. Every moment he stays alive is an opportunity for God to save him. And the family that's moved towards quality or living as well as possible, excuse me, she hates being in the hospital. She just wants to be home. We really worry about her suffering. I want any medicine that will decrease my pain, nausea, itching, so I can be with my friends and family and do some of my favorite things in the last couple of months. And then patients that want both, we're hoping that this next drug is going to be the thing that controls this disease and also worry about putting his body through much more. And once you're at least in these categories of one or the other or some overlap, you can consider how you would change the way you frame your decisions, kind of like what we talked about with that initial setting the context for Gretchen Swarzy. So for live as long as possible, if there's a child with severe neurologic impairment, but this might be the patient that you talk about a tracheostomy. Obviously we have an ethical standard to set the limits, a zone of discretion about what is a reasonable thing to offer, which is a whole separate conversation about non-beneficial care, which I would love to talk about another time. But that would be the family that might consider that. And live as well as possible, you're talking about discontinuing events in a child with advanced lung disease or discontinuing artificial nutrition, which is really a hard thing to do. Enrolling in home hospice. So that group that had the nice colorful graphs looking at the surgical trajectory based on the type of primary diagnosis, then went back through and looked at what were the stated goals of the surgery that they had. Was it life extending, life enhancing, or both? And in patients receiving palliative care, a quarter, 26%, wanted to extend their life. So in peds, unlike in adults, you can have both a concurrent intent of cure and comfort. And so even though these children were all receiving palliative care, 25% had surgeries with the intent of extending their life. And 37% was more of a quality focus. And then other reasons in the 30%. And then they looked not just at the intended goal, they tried to get more granular. It's not just living longer or living better. What's the actual purpose of the operation? Like we talked about with Dr. Swarzy's, diagnosis, feel better, live longer, etc. And 30% of these procedures were done to get a diagnosis, 30% with an aim of a cure or repair. Only 13% were supportive. So when you have seen articles about palliative surgery, we're usually talking about, should we operate on malignant bowel obstruction? That's a symptom-based operation, right? And If I need to plug this in. Oh, no, you can still see it. Okay, great. Um, but that kind of operation is only 13% of what these patients are undergoing. So that is a palliative surgery, but it's a small component of what they're actually undergoing. We found that the CV and cancer patients underwent 56% of their curative repair interventions, and the neurologic group, or the group with genetic conditions, had over half of the supportive interventions. So they then took those bar graphs looking at the when they had surgeries and how many surgeries, and they broke it down by the reason they had the surgery. So in the cardiovascular group, this color here is describing curative repair. So a patient with hypoplastic left heart is having many more surgeries early on to address the heart and try to cure that problem or repair that problem rather than G-tubes. Versus when you look at this neurologic group, there's no cure surgery happening here. These are supportive interventions, okay? And for the, I'm gonna go back one, for the genetic group, most of their surgeries are done for diagnostic purposes, okay? So it's just thinking through, what are we hoping to achieve for these patients so that we can, in the long run, tell them if we're meeting that objective or not, because there's different reasons depending on what operation we're doing. So if we move beyond trying to lengthen life or trying to generally make quality better, or talking about the specific objective of the operation, why don't we broaden it? Like, what are the actual goals for these families? And so they did a study of the families who were involved in this pediatric palliative care network and asked them about their standard of 5 different goals, and they would show the 2 of them, whether it was quality of life or life prolongation, quality of life or health deterioration. I'll show it on the next slide, the 5 things. And they asked them about ranking those goals multiple times while they were enrolled in palliative care. And they did this for 680 patients of 603 kids. Of note, based on that question and those 6 cardinal questions for pediatric palliative care, asking about goals, thinking about financial challenges that these families are meeting, 17% reported severe financial distress and 50% reported moderate financial distress. So these patients' families are in challenging positions. So the 5 things they ranked were between quality of life, seeking health, seeking comfort, disease reduction, and longer life. And while quality of life was at the top in terms of the bigger importance score, look at those interquartile ranges. They're huge. Like, there was a huge discrepancy, which means that what I'm trying to summarize with this statement is each family prioritizes different things. And if you don't ask, you won't know. So don't make assumptions about what matters to families. And there's some trends, though, based on the type of problem you have. So all problems basically ranked quality of life first, health second, comfort third, disease modification, and then life extension. The only group that was flipped was in the neonatal group. They prioritized life extension over disease modification, which makes sense. But in some groups, like the neuromuscular group, thinking about a patient with Duchenne's or other things, their quality of life is wider away from the disease modification. Versus when you look at malignancy, quality of life and life extension are much closer in how important they are to families. Finally, they ranked how these priorities changed over time as their disease progressed. And they found that in 80% of patients, for 80% of parents, the goals changed over time. So not only do you need to have these conversations, you need to keep having these conversations as things change. And 35% changed their top goal. So comfort went from being third to second for most people. And the importance of life extension decreased as time went on. For patients that had parents that had greater differentiation, meaning at the start it was clear that the importance of quality of life or life extension was much more than the rest relative, they stayed that way. In parents who were kind of equally balancing many of these things, there was a lot of flip-flopping depending on when it happened. So then, how am I doing my time? Okay. Then this group went even further to try to figure out some more granularity in terms of the things that actually matter to these parents in these really difficult positions. So this study looked at patients or parent priorities in end of life for kids with cancer. And this was in parents who had lost their child. And there were 61 parents that were involved in this study. I think people are nervous about studying this population because we think that we are going to add to their grief, right? And it feels really insensitive to say, tell me about your kid's death while you're grieving, right? But 85% of these parents, now obviously these are people who volunteered to be a part of the study, so it's a specific population, right? But they were comfortable answering questions, and 74% said that little to no distress was 0% describing great distress and answering these questions, and 90% felt like they had little to great benefit by doing this. I just bring this up because don't be afraid to study this population. It's important to figure out how to make it better, and it doesn't necessarily mean it's going to add to patients' and families' grief. So they looked, I'll show you this real quick, but these are the various things that they asked about ranking. There are things about communication, hospital resource use, interdisciplinary care, symptom management, and meeting patient and families' preferences. We'll look at this more in a second. The top things consistently were symptom relief for their child, feeling that their child's needs were heard, and having goal concordant end-of-life experience. Things that were the bottom of the list were limiting hospital-based interventions, limiting ICU time, avoiding CPR, avoiding chemotherapy. Those are the things we usually study, right? And the least important was parents' psychosocial support. Now, this gets into a lot of the idea of good parent beliefs and a lot of family psychology we could get into here, but parents always deprioritizing their own psychosocial needs. So I think there's a lot of additional things about why that was less important, and we should definitely still support the parents, right? But they listed it as least important. So up here, number one thing, satisfactory symptom management, child's needs heard by the healthcare team, goal concordant care, care preferences elicited from the parent, location of death, aligned with family preference, prognosis, communication between the healthcare team and parents, having palliative care involved. But then down here, the things that really didn't matter much to families after their child had died, whether they avoided chemo, the psychosocial support for parents, whether they avoided the ICU, had access to an emergency room, avoided CPR, had a private spacious hospital room, avoided a ventilator. Those are things that matter less. So the paper specifically says that measurement of hospital resource use ranked low in priority for our patients and our parents in our study, even though such measures are commonly used to assess population level end-of-life care quality for individuals with cancer. Other studies found that families expressed ambivalence about the measures of hospital use. There may also be unintended consequences of predicating quality on hospital use measures, given that many factors, including systemic racism, social determinants of health, and financial incentives for health systems to adhere to publicly reported measures, greatly impact the dynamics of end-of-life care. Taken together, these studies prompt clinicians to recognize high-quality end-of-life care for children with cancer with a greater emphasis on person-centered measures. So that leads me to my research questions, which I am here to recruit all of you to come help me figure out. Okay? Students, residents, colleagues that want to collaborate. These are the things I want to try to figure out over the course of my career. If commonly measured variables like healthcare utilization or life extension, like 30-day mortality, they're not what matters to these families and these really challenging patients, what should we be measuring? What are the outcomes that we should be holding ourselves accountable to as surgeons if 30-day mortality misses the mark? And then how do we provide personalized outcomes tracking based on families' goals? If a family wants life extension versus that family, 30-day mortality matters. For a family that wants to prioritize quality, that doesn't matter as much. That child living 30 days might be the opposite of what they wanted. Wanted is the wrong word, but And then how do we track based on, we've got precision medicine for a million other things. Why not families' value systems? And then to add to the layer of complexity, how do we transition this into the prenatal, fetal, and neonatal space, which is even more complicated? So I have some preliminary data that I will come back and start to present about, but I've been working with this group at Arizona that does prenatal palliative care, and they group people into a comfort focus, a life prolonging focus, or something in the middle for patients with 25 diagnoses that are likely not going to live beyond a year. And we track how, if they get home, how long they live, how many interventions they've had, if family had a chance to do memory making, if they could hold them, if they had time for religious things, and we're tracking it right now. So I'll come back in a couple of years with more information. But these are the things I'm hoping to answer. Please help me. In summary, all surgeons provide primary palliative care. Surgical communication is an important skill, and there's new research to suggest that there's better ways to consent. Pediatric palliative care has unique differences from adult palliative care. And many kids with life-limiting or life-altering conditions have surgeries, many of them by us. And we owe it to them to ensure that they are goal concordant, and then we track our outcomes based on what actually matters to the families. And here's some obligatory photos of my children. All right.
Thank you, Alexa. Any questions?
Thoughts?
I guess my question is, with families that have another complexity with language or barriers to care, social determinants of health. My question is, in families that have other social determinants of health, like rural setting or difficulty access to an ED or language difficulties, how does that add complexity to palliation?
I mean, huge complexity for access reasons. Also, importantly, from a research perspective, they are not studied right now. In both of those parent studies, they were 95% white. And almost all at big academic centers. And the mothers were older, or fathers were older, and had higher degrees. So there's a whole subset of the population that is just not even included in these studies. Part of it is that people worry about further burdening people that have additional challenges of either marginalization or less resources by trying to also make them come in and do studies and things. But by self-selecting, because of that, you're also missing out on getting the full story of what's going on. Okay.
I have
Yeah.
another question.
Sure.
Sorry. So I also wonder about whether there's a difference in outcomes if the physician is of the same culture or speaks the same language of the patient's family.
I'm sure there's data out there about that in palliative. I don't know, but I've seen some studies in pediatric surgery done by some of the people I trained from under Colorado that said clinic settings, in terms of like understanding and feeling heard and understood, if you speak the same language, is higher.
For the studies that you talked about where they surveyed, like the families of these patients after the fact they've already lost their child, and they're saying like what is important to them kind of retrospectively, was there any like discussion on if in the moment when they were going through these processes, they may have thought something was more important to them, but now that they're looking back on it and their child is already, passed on, they're kind of thinking more like, oh, in the grand scheme of things, that wasn't that important. Like, is there kind of any like bridging to that? Because we're going to be using this data to theoretically help people when they're in that moment, but do they have different priorities at that time versus when they're looking back?
Yeah, so there's layers of like, are we treating the experience of the child, of what they're going through, and are those our goals, or are we treating the way that we anticipate the family to have complicated grief? Are we helping their grief experience, or are we treating the child? So that's another like challenging family dynamic. But I think those studies are specifically looking at, with the benefit of hindsight, what are the things that you might have done differently, or with the benefit of time to reflect, what were the things that actually were meaningful to you?
To Nargi's point about rurality and access, something that I've come to appreciate, I guess, or a lot of the NICU baby, non-NICU baby, are in the hospital while their parents are not there because of the geographic differences. And I wonder if the parents' responses to the questions about what matters, whether life altering, life extending, or comfort, are influenced by not being present at the hospital and seeing their child in the care setting and getting the advanced support. I would venture to think that it would alter their thoughts about what they want. Shout out to the retirees that go and hold the babies at the NICU. I think that's awesome because it's wild. But
Yeah.
my question in the over time, the parents change in their response to what is important. The one that was most consistent was health. What is I guess how is that defined, that question, and what does that mean?
Yeah, I think just feeling, they described it as being like more normalcy, like less extensive need for medications, assistive technologies, like overall feeling more like a typical child. Marcel.
Thank you, Dr. Robbins. That was a great talk, and I think very useful because regardless if we're PGY1 or PGY15, we all go with patients, have to obtain informed consent. We have to help them navigate through these difficult decisions. I thought about the slide you mentioned where obtaining informed consent when we think it's more benefit or the benefits are greater than the risk of the surgery, but they still are uncertain to go through with surgery because of cultural reasons or any other reason. How do you navigate when you talk about the surgery, they in the end agree to go and proceed with surgery, and they still have an adverse event? How do you handle those conversations after?
Don't say I told you so. That's not helpful. I think when you have a complication, you do not move away. That's when you lean in to your families and your patients. So I think you align yourself by shared disappointment, right? You say like, I'm really, we really hoped this wasn't going to happen. It's really disappointing that it did.
I can tell you saying that will decrease the chance of you getting sued as well. Rather than taking the back seat, never seeing them again, not forming that personal connection after the devastating complication.
Even the words "I'm sorry" have been shown to they don't count as an admission of malpractice. It does count greatly in that bonding. The words "I'm sorry" are really helpful for it.
I think also building on that experience to prevent further escalation of care. So using that experience you had to say, hey, remember when we were deciding what to do and we felt like more intensive interventions were going to help us achieve that goal? We have history demonstrating that it's not going to. So I have more data now to suggest that replicating that with an additional intervention is probably also not going to reach that goal. However, the risk or the burden, not just risk, right? Burden is up.
I have a question. Can I make one comment about that? Sorry.
Yeah.
One thing that I've been surprised by when people have complications is that families and patients often worry it's their fault. And I think that, or they worry it's your fault. And we've talked a lot about our feelings about it, but I think validating them, they'll ask like, did my coughing cause my hernia or my bleeding or whatever? Or did I get out of bed too quickly? And so I think that holding space for that and some reassurance can be really helpful because they have a lot of guilt too about what they're going through sometimes.
Dr. Lassiter, fantastic and timely presentation. How do you think media is influencing our patients' ability to come to these conversations, prepare to discuss the goals? I read an article recently about the PIT and other shows are potentially eroding trust in physicians. Perhaps their depiction at the end of life scenario has a positive impact. What are your thoughts?
I think some of these TV shows can provide examples of what things might look like, in terms of thinking about things like chest compressions or ICU stays or what it's like for your family to sit at your bedside while you're struggling. I think in general, there is an erosion of trust in the healthcare system, which is difficult to navigate. And we see it a lot in peds. As you can just look at how many children we're treating for problems that vaccines could fix, right? Or prevent. So I don't know. It's hard. It's hard to feel like you have to prove to people that you have the expertise that you have. But I try, when I'm about to have a difficult conversation, I try to ground myself in empathy that they are scared and they are trying, if they have an erosion of trust in the healthcare system, it's probably a system problem and not an individual problem. So trying to have empathy for the fact that they are scared about their child's life. And so I'm going to take a deep breath and give my references, and I'm just going to say my judgment, and then they can decide to take that opinion or not. A lot of thoughts on that. Okay, so Rochelle.
But one of the things that I think about a lot or worry about when consulting palliative is that I know we don't have enough palliative care physicians, and like that we're burdening their team as well. So I'm curious if you have any thoughts about that, and or like what we can do when consulting them to make their job a little easier. And just like if you have any thoughts about when to make that decision. Obviously, it's complicated.
That's super considerate. They would be super pleased to hear this conversation. I think
that was actually my question as well. Is that there's not enough hours in the day to do it all, and not enough people to do all the work. I mean, think about our census on ped surgery. What are we carrying? A census of 25?
Yeah.
Sometimes 40. And can you imagine? And they're sick kids.
Yeah.
Wow.
Yeah. So what I would say is let them triage, don't triage for them. So just send the consult and say, if you don't think this is appropriate for right now or for another time, let me know. But I think they would benefit, because I think all patients would benefit from talking with you guys. And then they can say, I'm like, we've got all these other things. I'm sorry, we're not going to be able to get to that. But I would let them decide, because it might be a slow day and that patient might really benefit. And then show off the legwork you've already done. So if you've done the primary palliative care, you've already had a big goals of care conversation. They might not have to start from scratch. They might be able to get in halfway through their pitch because they know what you've already said. They could say, based on what I've heard in your previous conversations, this, and this matters to you. So just tell me about your kid a little bit. That's the, boom, conversation that goes from an hour to 20 minutes, right? So I think the things you know about symptoms, the thing you know about their goals, the conversations you've had, giving them the context that you've already obtained in the concise way that medical people speak to each other rather than the hour-long conversation with grandma, it helps them too.
This was a really excellent talk, and these studies, I didn't even realize there were so many studies out there with all these topics. So it was excellent to be able to see those. As far as thinking through how you study these topics, it seems like the most thorough and possibly the best ways would be with interview studies or survey studies of the families. Mm-hmm. But is there another way to go about studying all of this that might be less distressing to families?
That's what we'll figure out together.
Yeah, thank you. This was really good, and I think we can use this even as a framework for a lot of things. So I appreciate that. How do you go about navigating? Because I think there has already been times where we'll consult palliative, we'll say tell the family hey, we're gonna have some experts come talk to you, and the family very much, probably because of a lack of understanding, but it's no, I don't want to talk to those people. How do you? And that's obviously they're right, but especially with these people and these kids with long hospital stays, how do you go about re-engaging, in 2 weeks when things take a turn, or when, the family's initially refuses to see palliative?
So I would, depending on where you end up, I would talk to your palliative team because they feel differently. I've seen a spectrum of palliative providers. Some of them don't want you to introduce it because just like a chaplain, part of their job is explaining what they do, right? So a chaplain I worked with for a while, he was I don't want you to tell them would you like a chaplain to come see you to talk about your religious beliefs for someone who's not religious, because chaplains help people with spiritual experiences, not religious experiences. And there is no more spiritual of an event than having your child die, right? So in the same way, palliative care sometimes likes to just come in and introduce themselves. Other ones feel like having you fire a warning shot that they're coming kind of doesn't surprise people when they show up. And so then what I would say is that thing on the first slide, which is, we have this team here that helps provide additional layer of support for families that have like a life limiting or life altering disease as they're preparing for the future. And I just would love for them to come talk with you to see how they can support you through this. They're called palliative care. I'm not worried that you're dying. I just think that it would be really helpful to see if they can help. So I'd appreciate if you would be open to that.
Yeah, I think that's that concern because I feel like with palliative and people are like, whoa, you had these people come see me, like you didn't tell me it was that serious, like you didn't tell me they were coming, and now I think I'm like dying or something, and so.
Yeah, you can quote some of these studies that what we've found is if you meet palliative care when you're already crashing, it's too late. We have these teams come talk with you to try to help you understand. It's hard to figure out what your goals are when someone asks you, but if you have the time when your family member is well to think about what matters, then it's not the first time you're going through the mental gymnastics when there's also an emergency. So I just want you to meet them early on to have a chance to talk to them and think through things when it's not an emergency, because we're not in an emergency right now.
I have a follow-on comment on that. I would just really encourage people to change their thinking about what palliative care is, which is what Dr. Robbins is trying to do with this slide as well. So we have patients who have chronic nausea. There's no chance, they're not dying, they're going to be fine, they're going to work, they're doing all this stuff. They have chronic nausea. Palliative care is excellent at managing chronic nausea, right? It's not, so you have to think about, this is the goal of palliative care. I think one of the main goals can be symptom management, right? So it's not the difference, it's the difference between trying to get better and trying to be well, right? And so if you're talking about that to the patients in that way, I think that's something that helps them get over that hump. Is that?
Yep, totally.
Yeah. And then the second thing that I would make a comment about your talk. I fully agree. This is a really excellent talk. And even though I had high expectations, you continue to exceed them. And so thank you for doing that, for speaking. I fully support the idea of bringing the fundamentals of communication curriculum. I think that's a great idea. My concern about the fundamentals of communication curriculum is it spreads it out too much. Yeah. These are skills we need in the first and second year. I think we have almost fully entrusted consents, for example, to first and second year residents. It's pretty rare that seniors are having those basic conversations. It happens, but it's more rare. And so I think we need to kind of bring that down a little bit. And I would be fully willing to work with you on that. And all of the other things, the fantastic de-escalate curriculum that people have worked on. There's a lot of communication in surgery that we should really focus on. Back from when I was a resident, we had an hour of communication lecture, that we need to do this more. So thank you for bringing this to us, and thank you for amplifying this really important thing. I know there are a bunch more questions. I know we're also over time, and so please access this again. Please remember that all of our grand rounds are recorded, and you're able to access those online if you want to do that, and just kind of keep refreshing. This is something you might need to hear more than once.
Thank you.
Thanks.